What advice would you offer to clinicians who are managing patients with complete virologic suppression, but whose modest immune reconstitution may be worrisome to either the patient or the practitioner?
This is a common scenario, and unfortunately there's really not much that we can do about it. Studies show that adding drugs, switching drugs, really makes no difference in terms of CD4 outcome. If you suppress the viral load with any regimen, that's about as much as you can do in terms of CD4 increase. Studies are very clear on the fact that the choice of regimen isn't going to make that much difference. We do have some data suggesting that NNRTI-based regimens, especially efavirenz-based regimens, give you a poorer CD4 response than regimens containing other classes of drugs, and yet switching from efavirenz to another drug doesn't seem to boost your CD4 count significantly. So that doesn't seem to be a solution. In the unlikely case that you're still using AZT, I would certainly get the patient off AZT, in part because it's associated with bone marrow suppression and can reduce the CD4 count. We do now have evidence that patients with a CD4 count between 100 and 200 who have undetectable viral loads on treatment are at extremely low risk of getting PCP, and so continued use of Bactrim in that group may be counterproductive because it could also suppress the white count and therefore the CD4 count. But short of that, there's not much you can do except reassure the patient that although it would be desirable for them to have a higher CD4 count, they're certainly much better off than they were before they were on treatment. And I think that this just makes the point of how critically important it is to get patients diagnosed and in care and on treatment as soon as possible. If we were treating everybody from the outset and diagnosing them at an early stage of HIV infection, we wouldn't be facing this problem because they would be starting out with high CD4 counts.